GREENLIGHT XPS standardized technique for optimal outcomes. Step 2. Video and narration by Dr. Kevin Zorn. Here we will be demonstrating the left lobe treatment with a relaxing 1 o'clock incision so as to allow the bulk of the adenoma to fall into the pre-created space from the floor treatment. Note that we are firing along the natural surgical plane of the capsule that was pre-established during the 5 o'clock incision. We are simply firing from between a 3 o'clock and 1 and 2 o'clock position in a slow, controlled fashion and optimizing our workspace by a non-dominant hand camera torque toward the capsule. Note the demarcation between the natural capsule fibers, which are white, as well as the prostate adenoma, which has a yellow, tan, brown nature. Here we begin by aiming our fiber up toward a 1 o'clock incision. Care must be made, especially in small prostates, not to retract too quickly or abruptly insofar that we may be treating the sphincter. As such, small 1-inch cuts, as can be seen here, stopping, having a look and seeing what has been created, and reestablishing that initial groove to the capsule, I think is very important. So as can be seen here, those muscle fibers of the capsule become more prominent once the laser fiber has gotten down to that level. Unless one sits in the same spot, it is quite difficult to perforate through the capsule and lead to significant bleeding. Nevertheless, one must be cognizant and attentive to ensuring not to get into any trouble. Once this plane is identified, as can be seen here, simply staying on that same position and breaking down those the adenomatous tissue, allowing the adenoma to fall into the floor, which has been already treated. What this allows is the surgeon, as can be seen here, tapping the tissue to identify both margins of the dissection. And again, in some instances, some people may refer to incising the tissue out and removing these strips of tissue for pathological analysis, or to simply keep it on its same stock and to treat the tissue. With the 180 watt setting, this can be done quite rapidly and quite consistently. So again, the key points are to cut down to the capsule at 5 and 1 o'clock and follow the natural plane. Compared to the conventional standard TURP, these initial grooves can take a bit more time, particularly in thicker prostates, but nevertheless, the outcome for the patient is as good, if not better, insofar as bleeding and recovery. Here we continue to treat, and what is most important to the novice surgeon is ensuring that the sweep speed and distance are optimized according to that particular tissue. As I mentioned in step 1, the prostate tissue is very heterogeneous and very inconsistent, and as such, it is very important during the treatment to slow down and work on the optimal sweeping speed so as to create a very smooth surface, as can be seen here, compared to the previous generation lasers or novice surgeons where there may be very irregular surfaced areas, which I feel leads to increased necrosis and increased dysuria rates. So it is very important to ensure complete tissue ablation prior to moving on to other aspects of the surgery, which in this case would be the contralateral lobe. One of the most difficult or challenging aspects of treatment is the anterior apex, the tissue that sits near the tip of the sphincter and anteriorly where the visual markings, such as the verumontanum, are not seen by the surgeon. Again, this is why I make that pre-marking before the initial treatment with the coagulation of that margin. And it's also important, if the novice surgeon is uncomfortable, to take a minute or two just to stop and get their bearing straight in terms of positioning. So it is very important to be thorough and rigorous and to ensure the completion of this aspect of the treatment on the patient's left lobe prior to engaging on the contralateral side. So as such, the bladder neck and the mid-prostate have been well treated, and what is left behind is the anterior and apical tissues, which I will usually lower the power setting to 120 watts so as to allow for minimal amount of damage near the sphincter, be it by heat or direct laser treatment. Here we continue to treat that anterior lying tissue. If there's any question, we come back to the bladder neck, assess the surgical capsule, and assess the amount of remaining tissue. Occasionally, one will simply vaporize the remaining few millimeters of tissue along the floor and the lateral lobe to ensure a very smooth surface structure. Again, I feel that it is these small details which lead to better outcomes and more prolonged outcomes and less irritative voiding symptoms in the recovery phase. As we know, with all surgical tools, what is as important as the technology is the surgeon, their experience, and their technique. What can be seen here is that that anterior tissue is something that, in my experience, is sometimes undertreated due to technical challenge. And it is this tissue which, in 5 to 10 or sometimes 15 years, regrows the most to re-obstruct the patient and lead to need for additional surgery. If adequately treated down to the capsule, those risks should be extremely low. And as such, an important aspect of the treatment, not only to clear up the middle lobe, in this instance, the lateral lobe, but also ensuring the completeness of that channel down to the verumontanum, which is the end point of the surgery. There are many who may simply prefer a channelectomy and therefore centripetally opening up a working space, which obviously will take a lot less time, but the completeness of resection and the durability are that which is questioned. This completes phase 2, the left lobe treatment. We will now move on to step 3, which I invite you to follow along.